without asking my general practitioner first, and then he sends, my orthopedic doctor then sends the record of what happened. He will send an information of what happened to my general practitioner, so I can skip over that process. One of the things
but if I may, on this one, I think the rationale for this reform is very strong. I see two major advantages. Is that if you go through your general practitioner, there are less chance that you are going to see a specialist, because you will think that you need to see a specialist, but your doctor knows better than you. So it has reduced what I would call the overuse of specialists. Second point, it is very important for your general practitioner to be aware of everything dealing with you. And he can only be aware of what's happening to you, your general health situation, if there is a risk, cardiovascular risk or whatever, if he's informed of your every move. He's like an advisor, plus he's an advisor who can treat significant parts of your health issues. So there is a very strong rationale behind this. And again, you can choose whomever you want.
Talk a little bit, Jean-Baptiste, about the carte vitae, is that it, or vitale? My French is just, I'm going to have to take French lessons. That's the next thing I have to do. Where the patient presents his, it's a microchip containing the reimbursement information on his electronic card, and this transmits all the transactions to the medical procedures that the person's doing, the hospital, the lab, the tests, the x-rays that have taken place, and it's sent to one system. So this is a little bit, I think this is something that our own doctors in the United States, I know from the Illinois Medical Society, that is something that they really want also, because they talked about it here. They said the use of information technology in healthcare delivery should be encouraged to improve quality and safety of care, enhance efficiency, and control costs. And that's one of the reasons we have a lot of costs here in the United States, because we need a lot of people in doctors' offices just to figure out how to bill insurance companies, and each one has a different qualifications of what they expect, and I believe that the French system has eliminated some of that overhead. Can you talk a little bit about that electronic health information system?
No, I think you've described it very well. The only thing I would have to correct is maybe the pronunciation. It's carte vitale.
It'll never happen. Yes.
And maybe stress another advantage of this carte vitale, which is a smart card, as you rightly pointed out.
It's an electronic card.
Electronic with a chip.
Microchip. Okay.
Is that, for instance, you have a prescription from your doctor to get some medicine. You can get this medicine from the pharmacist without having to disburse anything. Because that's done directly on the chip and the health insurance. The public health insurance.
So they don't have to pay anything. They just send it.
No, if you use the smart card.
Yes.
That's one of the advantages.
And everybody has this.
Everybody has the, yes. Now it's yeah, absolutely. It's been tested for some time and then implemented throughout the country, yes. I have to insist, though, upon the difference between this and a medical file. It doesn't contain medical information. It contains all the information about which kind of visits you've been made to the doctor, or, as you said, the laboratories, or everything linked to the payment. That's what it is about. It's not a medical file.
So this way the patient's information stays private. I think this is one of the things that in the United States we're a little bit worried about, a lot worried about probably, not just a little bit worried about, that our health information is going to be central, and anybody that can get our information on our health. Right now we have the HIPAA laws, which are the privatization laws that secure that our files, our health information is not, if my husband wanted to get some information about me, he cannot without my permission. And which there's pro and con on that, because sometimes, a spouse will hide something so their spouse doesn't know, and it could be, you know, it could be life or death situation, and we don't know about it, and it can be, you know, this way. Sometimes if the spouse knows what's going on, you know, you could help with the right dietary and other information that you can work with your spouse. But sometimes that everything is very, very private here in the United States, and I think people are afraid that if you know, they're electronically will go to a public area, and anybody who's anybody that knows how to retrieve this information can get into the system. Is that one of the reasons why that this information has now not been put on electric chip?
Well, actually, there were two different projects: the electric chip, which has worked fine, as we said, and the medical file, which has not. Which
could be also on another electronic chip of some kind.
I am not sure. It would be more like a database, you know, than on a chip, and it has not so far been really successful in the sense that we've run against quite a high number of problems, technical, managerial. And it has proven, because there was a study made a few years ago. I mean, first of all, it was implemented in 2004, and the study was done 2 or 3 years later. The study showed that we underestimated the complexity of this approach. It's not questioning the idea itself, but I think it leads more to the idea that we probably need an operator to do that. Because it's a job in itself. I mean, it's really a set of competence you need to put in place to get all this information and get it in a usable way. So there's a heavy work ahead if we want to implement it. And right now, the government is putting more the accent on cost control and reforming the hospital than in reviving this medical file.
You know, let me ask you something. This came on one of my, that I picked up on the healthcare system in France. There was this Dr. Marie-Laure Albi, a general practitioner in Paris, who shares a practice with 3 other doctors, said, government set fees don't provide enough money to cover expenses. The practice where she works offers patients care 6 days a week, 12 hours a day, including house calls. The 4 doctors share the cost of 2 secretaries and 1 nurse. What is that about, that the government said fees don't provide enough money to cover expenses?
Well, there is no doubt that the situation of doctors in general and practitioners is tougher than it was 30 years ago, let's say. And the reason is the cost. I mean, the cost is naturally rising in every country. It's rising faster than GDP. Whereas if you take the taxes on salaries which are financing the healthcare, they're rising roughly in sync with GDP. So the government has had to introduce some more controls and set some precise rates for the price of of consulting your doctor. And you can go higher than this, but then the outpatient is not reimbursed. So he would prefer to go to a doctor who is charging the regulated price. So yes, the situation is sometimes difficult for doctors. That's one of the constraints we're facing. That's one of the challenges we're having. So it's never to say that our system is perfect. Is that the professionals have had to make an effort in restraining their costs and their lifestyle. Let's put it this way. Has maybe been impacted from what it was 30 years ago.
See, a lot of our doctors are doing procedures, a lot of procedures, because they have to pay, in the United States, they have to pay a lot in malpractice insurance. In fact, my son is a general surgeon in Tampa, and I know that he was talking about how much money that he has to pay for malpractice insurance, and he felt that tort reform needs to be. This is the number one thing, that the tort reform, that people cannot keep suing doctors for everything that they do, and it's